Hello, everyone. My name is Carrie Rubel. I'm the Executive Assistant at the Radiosurgery Society. Thank you for joining us for today's webinar, SGRT for SRS SBRT treatments, better dose distribution and delivery, and utilization of SGRT. We would like to thank Vision RT for supporting this webinar through an unrestricted grant. Our webinars are free and open for anyone to attend. CME certificates are available for those attending our live webinar broadcasts and are at no cost to our members. CMEs are available to non-members for $19.95. Everyone attending today's broadcast will receive an email with follow-up instructions on how to obtain CME certificates. During today's presentations, you can submit your questions by clicking on the questions box located in your GoToWebinar window. Please do not hesitate to submit questions at any time during the presentation. All questions will be addressed at the end of the session. Now let's get started with today's webinar. It's my pleasure to introduce you to our moderator, Dr. Sua Yoo. Dr. Yoo is currently an Associate Professor and Director of Clinical Physics at Duke University Medical Center in Durham, North Carolina. After receiving a PhD in medical physics from University of Wisconsin-Madison in 2003, Dr. Yoo joined at Duke in 2005. Her special focus is on treatment planning and QA, AI clinical implementation, and clinical development of SBRT processes. Welcome, Dr. Yoo.
Thank you. Welcome here, and today our webinar is SGRT. I'll introduce Dr. Koontz, and she was trained at Harvard Medical School and went through UNC and also residency at Duke University. I worked with her, and she joined as an assistant professor at Duke in 2007, and she served for several leadership roles, and she joined Genesis Care in 2021. And worked until 2023, and now she's the leader at AdventHealth Cancer Institute across the Florida area, and she is expert for SGRT, and she'll talk about how SGRT is utilized for SBRT SRS. Here's Dr. Koontz.
Thank you very much for the introduction. Can you all hear me okay? I'm having a little bit of trouble on my end. So, Adi, just wave if we're having trouble.
Yeah, can hear you.
Yes, and we see the presentation slide too.
All right. Okay, so thank you very much. It's a pleasure to be here today and talking about SRS and SBRT, something I've been doing for a long time, and what we've learned now as I in this role here at AdventHealth have been using surface guided radiotherapy more.
Dr. Koontz, it seems like we're having some difficulty hearing you. I can see your slides and I see them advancing, but I actually can't hear you speaking.
And its effect on treatment precision.
There you go.
Oh, now I can hear you.
Do you, I'll keep going. If I have more trouble, Adi, I might come over to your side. Okay. So why am I giving this talk? And it really is driven on my expertise in the stereotactic side of things. My clinical specialty is in prostate cancer and oligometastatic care. As Dr. Yoo had mentioned, I was at Duke Cancer Institute for a long time. There I developed the LINAC-based prostate SBRT program. And as part of that, we did both nodal and a lot of bone metastases, developing the spine SBRT program at one of our community affiliate centers. Then while I was at ECU, I had experience using both the LINAC and their CyberKnife for prostate SBRT and selective metastases. Currently, I'm the chair of the GU11 study for NRG Oncology, which is a study looking at SBRT plus or minus relugolix for prostate oligometastases. And now in both my administrative and clinical roles, I have experience and a growing experience with surface-guided radiotherapy. We have a gamma knife service here, as well as continued clinical work for prostate cancer. So that's just a little bit of my background and the where I'm coming from from this when thinking about stereotactic and surface-guided. Okay, so just to really set the stage, and I'm speaking here to the this esteemed group in this society. This is not news, but I was really kind of wanted to look back at really where the field of stereotactic treatment has come from. And actually the first published study that's referenced in PubMed is actually back in 1945. But at that point, it was really all stereotactic, was really around surgical approaches, and really began to shoot up in the 1980s. And you could see very high numbers of publications in the recent years. Just as we sometimes get caught up with insurance coverage and around stereotactic versus IMRT type approaches, and really, but as a whole, I think our society, radiation oncology, medical physics, the consensus was really around, it's not the number of fraction, it's the delivery approach. And SBRT that would be immobilization. So very important, very strict immobilization. And that allows us to deliver high dose radiation with a sharp penumbra. Stereotactic radiation requires stereotaxy, being able to target with 3D high resolution imaging, ultimately resulting in sub-centimeter accuracy. And it's really the AMA that set codes defining SBRT as up to 5 fractions. But I think so we have both what we do for billing purposes, but also just thinking that it's really the technique when we're labeling it as stereotactic radiotherapy. So when we think about how our technique improves over the years, and those 4 components that I've put in the top right of our slides, where did we come from? So as you know, 1951 was really when Lars Lexell put together that first stereotactic radiosurgery program, gamma knife. And so this was the immobilization and the precision available at that time, with the patient's head frame fixing onto this larger gamma knife arc. As stereotactic treatments evolved, we were able to develop non-coplanar and irregular target treatment with the use of LINAC-based radiosurgery. And in 1991, FDA approval out of Stanford for the CyberKnife, which allowed us to do extracranial targets. So those are really the backgrounds of where we started. And we've had a number of immobilization improvements over the years. These are old pictures, really, because I wanted to be company agnostic, but just showing, for both, the opportunity for frameless SRS, looking at for body radiosurgery and radiotherapy, being able to look at both immobilization and the targeting approaches that are needed. I do want to just throw in a reminder around, again, in addition to the targeting and the high dose per fraction precision delivery, there is also a unique radiobiology in terms of stereotactic radiation. And high dose fractions have a different mechanism of radiation mediated cell death than what we see with standard or even moderately hypofractionated radiation. So if you look here, there's a tumor in the microvasculature, so feeding this tumor. Low dose radiation is what we remember from radiobiology. These are direct death of cells, hypoxic cells, which are colored blue in this diagram, are radioresistant, but the normally oxygenated cells are going to have DNA damage, ultimately causing cancer cell death either by apoptosis, lysis, or other mechanisms. However, and that's a slow process as DNA damage occurs. However, the tumor microvasculature, that's very resistant to standard dose radiation over time. And so, however, with high dose radiation, the endothelial cells are actually rather sensitive to high dose radiation. And so with what you see with stereotactic is you get vascular disruption of those endothelium feeding the tumor, and therefore, whether the cell is hypoxic, whether it is normoxic, you're getting a much more, they all become anoxic because the vascular endothelium breaks down, you're not getting any blood flow into that tumor, and so then you're getting ischemic death from those cells. And so it's a different timing and it's a different process. And I think that's important to remember because we also are thinking about normal tissue endothelium, and that is why the margins are so important. That really feeds into my thoughts around what conditions are appropriate for stereotactic treatment. You know, certainly for the CNS, we're talking about brain metastases, meningiomas, AVMs. There's, that endothelial sensitivity to high dose radiation really makes sense as to why these vascular structures are ideal targets for stereotactic radiosurgery. Schwannomas and trigeminal neuralgia. In the body, we're looking at, again, areas where we need that precision, and also perhaps where the high dose per fraction sensitivity by the tumor vasculature overcomes the natural radiation resistance of the histologies. So structures like spine, lung, liver, pancreas, and prostate, as well as specific histologies that we are sort of traditionally radiation resistant. So the other part that I was thinking through as this talk is really what are the challenges with stereotactic radiation, and it comes back to these 4 critical components. And as we think about those, what we're really saying is that we need the immobilization to allow us to have high dose radiation with a sharp penumbra. But we need to aim that high dose radiation using the high resolution 3D targeting, which ultimately is going to produce the sub-centimeter accuracy. When we think about these 4 items, some of them are patient related and some of them are technology related. So being able to do sharp penumbra and the accuracy really relies on our equipment, and the immobilization and the 3D targeting in part can be related to our equipment, but often these are patient factors as well. And so this is where, other than the companies creating new technology for us to use, the easiest for us to improve upon is the immobilization and the targeting. So I wanted to just illustrate sort of our approach and addressing these factors in a few cases. So a first case is a 64-year-old man who was diagnosed in 2023 with high-risk prostate cancer. He had a prostatectomy, which showed disease outside of the prostate in the seminal vesicles, a positive margin, and he had a high-grade tumor with Gleason grade group 4. His postoperative PSA was detectable, although low, and then within 5 months actually rose to 2.06, which is quite high in the post-prostatectomy setting. And at that time, he had a PSMA PET scan, which showed a metastasis at C2, which was confirmed on MRI. And so you can see here, you can see my mouse, a change in the marrow signal at C2. So what were the challenges for him? So our immobilization for him was actually at a center where we do not have surface guided, and so we used a Head and Shoulders Aquaplast mask. The big challenge for him is that he is claustrophobic, and this was a big deal for him. We used lorazepam with the SIM in each treatment. He actually, well, we don't do this as a standard. His wife came in for the immobilization development and only stepped out for the CT because her being there in his mind really helped him calm down and be able to get through the procedure. And that we did that for SIM. We treated him with 8 gray ×3 using 6X flattening filter-free rapid arcs. This is an example of his treatment plan. And the other challenge that we noted is his head tilt. So again, even with the immobilization that we use, the red arrow shows there's a little bit where the to match using cone beam at the spinal canal, which was critical for him given this C2 location. And we still had, not everything matches up perfectly. And in clinical experience, we know this to be the case. And I think even with our 6-degree couch, this was one of the challenges where we needed to do the best we could looking at our critical OARs to make sure that we did not cause any harm. So I have a second case, and this is a 73-year-old woman with a history of, and I apologize for the spelling error, a left nephrectomy for a renal cell carcinoma. It was node positive at the time, and she had adjuvant immunotherapy, but she showed up with PET recurrent disease after 2.5 years. She did go on second-line systemic therapy, but she did not tolerate that well, and so we saw her for consideration of radiation. And here you can see my PTV outlined in red for this large solitary nodal mass. So for her, we did a full body vac lock for our immobilization, and we, able to secure her feet and arms. And the challenge for her was being able to get into and out of this device. We did use daily cone beam image guidance, and the challenge on that one was being able to differentiate on CT between tumor and normal tissue. For the mobility issue, this was just we just assisted her the best that we could. The team was thoughtful in building the mold to provide opportunity for her to swing in and out of the mold. And on the daily cone beam, I've actually been very impressed with our cone beam reconstruction here, but we really just use a narrow view that helps to improve resolution, particularly for larger patients. This is her treatment plan. We did a 9 gray ×5 to that nodal volume. And then my third case is a 74-year-old man who had a solitary hepatocellular carcinoma that had been previously treated with Y90 and then was found to have new disease on the MRI, liver segment 7, and was otherwise in good shape and was able to tolerate external beam radiotherapy. So this was out of the 3 patients, this was the one patient that I treated at our facility that has full surface guided capabilities. And you'll see his setup is much different. For immobilization for him, we used a wingboard. So we did not have the issue of him getting in and out of the large vac lock device. Here you can see the tumor really up against the diaphragm. And so we did use sort of a respiratory gated approach, which the surface guided was able to assist with as well. And so here his plan, so we did use a breath hold technique, and we treated him 55 gray in 5 fractions using a 10x flattening filter-free rapid arc approach. So just to summarize my clinical perspectives, I really, first off, where we look in terms of going from the original approaches with SRS and fixed head frame and technological advances over the years, we've had continual improvement with both technology and our cognitive approach as how we choose patients that are candidates for stereotactic radiation and how we deliver that treatment. Stereotactic radiation does have different radiobiology, and our treatment goals likewise are often different. We're treating gross disease with very tight margin. We're really looking at local control predominantly rather than trying to clear volumes of microscopic cancer spread. And again, really the 4 components of immobilization, accurate targeting, precise delivery of high-dose radiation. These are all the essential components of a successful stereotactic program. And I think as we continue to advance this component of radiation oncology, those are the areas where I believe we can continue to have technological improvements that help us take care of our patients. So with that, I'm going to hand back off to Dr. Yoo and my colleague, Dr. Robinson.
Thank you, Dr. Koontz. That was wonderful. And our next speaker is Dr. Robinson. He's a senior medical physicist at AdventHealth system. And he is also director of the medical physics residency programs there. He's the lead physicist for SGRT, and his research interests include SGRT and multi-target SRS planning and automation and Cherenkov imaging. And again, you can put questions in the question box, and we'll go through all the questions at the end. Thank you, and here's Dr. Robinson.
Hi, thank you for the lovely introduction, Dr. Yoo, and Dr. Koontz for a wonderful setup. So I'll be talking about better dose distribution and delivery, how SGRT is used in simulation planning, treatment, and dose visualization here at AdventHealth Celebration. We do have one relevant disclosure, is that AdventHealth Celebration is a center of excellence for VisionRT, and we provide site visits and consultation and product testing for VisionRT. My objectives for this talk is to us to understand the role of SGRT in SBRTs and SRS treatments, highlight SGRT's impact on current workflows that we use, and discuss, as mentioned, the role SGRT can play in the simulation planning, treatment, and dose verification for SBRTs and SRSs. A little bit about our center. We have 2 TrueBeams here in Celebration, a Siemens CT, 2 Align RT systems, SimRT, MapRT, Dose 13 Patient ID, products from VisionRT, which we'll introduce as we get along, but it's always lovely to see a picture of a hospital that was built by Disney to maybe function as a hotel one day, and now it's a hospital. So that's the beautiful hospital that we work at. So I like to start at the radiation oncology workflow and kind of work our way through and see where SGRT can help us make some sort of an impact. Our first step is always at simulation after the physician consult, of course, where the patient will show up and gets registered in either the CT, the respiratory gating, or 4D system, or both. And then, discussion about setup kind of finalizes. We kind of agree on orientation, which accessories to use, and immobilization devices, and we use the physician's input from consult and their view on how they want to treat the patient and what is available and what the patient condition is. Then we decide on the scan type, whether it's free breathing, DABR, or 4D, and then we scan. That information gets via DICOM information to the planner, and they can select their plan type, based on feedback from physics and the physician, calculate their MUs, do their second checks, and export the plan to the LINAC. On the LINAC, we ID the patient on day 1. If there's any dry runs or clearance checks that needs to be done, we run them on that day. Set up the patient into BBs or tattoos, perform our IGRT verification shift if we need to, and then we treat the patient. Now, if we want some sort of feedback verification, if we want to see how well our treatment went, we can rely on IGRT, and we can say, okay, the patient was positioned really, really well. We can do diodes or TLDs to spot check the dose at certain spots, but mostly we rely on visual inspection. So we look at the cameras, we look at the images, and we say, okay, that looks good. Now with SGRT, at each of these steps, we can use surface-guided radiation therapy to simulate the patient, to generate a clearance map for better plan optimization. We can monitor the patient for patient movement with a line RT, and dose RT utilizing Cherenkov imaging. We can visualize dead dose in real time. So as Dr. Koontz mentioned earlier, the advantages of stereotactic radiosurgery is that we have high precision targeting. We can deliver high dose radiation to the target and spare the healthy tissue around it. It's a short treatment course. It has a very good effective local control. And comparing with surgery, as we all started, it is non-invasive and can be used even for inoperable tumors. With SGRT, we have a non-invasive technique that employs optical or infrared cameras to capture and track the patient's surface in real time. It can help you precisely position the patient before the treatment starts and monitor them throughout the treatment. It can help you ensure that the irradiation is delivered accurately to the target without any need for invasive masks, markers, or tattoos. So when I'm thinking about SGRT for stereotactic treatments, going over some of the advantages we talked about, if we're looking at precision and accuracy, SGRT provides sub-millimeter accuracy in patient positioning and monitoring, which is crucial for the high precision demands of the stereotactic treatments. Motion management. SGRT is effective in managing respiratory motion and patient motion, accounting for tumor movement during breathing. This could lead for smaller treatment volumes and potentially higher doses to the target while sparing normal tissue. Real-time monitoring and correction. So with SGRT, you get a continuous feedback loop on patient positioning during your treatment and allows for immediate corrections if any motion occurs. So you can either stop the beam and adjust manually or adjust it small corrections from without it entering the room. And is very vital for accuracy of single or limited fraction treatment for SBRTs and SRSs. And we also have reduced setup time because you have that setup tools from SGRT. You can quickly set up a patient very accurately without any need for markers or tattoos or repeated IGRT images. So that reduces the patient's time on the table, makes it more repeatable if you have multiple fractions to do, and improves patient comfort. So let's jump to the simulation, the beginning. And usually our standard workflow is, like I mentioned, we register the patient, decide on orientation. If we're doing a DIBH or a 4D scan, we have to place a device and coach the patient to breathe at a certain way, and then we acquire the scan. But more times than none, we're kind of stuck in this loop where we have to make a compromise between the physician's need of immobilization, support devices, and what the plan actually would benefit from to the body habitus, the device location, the patient's breathing abilities, and so on and so forth. So it takes a while to kind of make the compromises that you need to make in order to finish the scan that way. With surface-guided simulation using SIMRT, we have a deviceless DABH and 4D simulation where a virtual patch is placed on the patient, and you can quickly obtain a breathing pattern and move the patch around if you want to find the perfect breathing pattern. You have workstations inside the room, inside the simulation, outside, so you don't have to run back and forth, and everything can be done from either inside or outside, and you can provide the patient with immediate feedback on the process. And we've seen that a lot of our complicated 4D or DABH simulations have narrowed down from about an hour and a half to about 20 to 30 minutes. So that's great for us. So here's an example of a 4D workflow, and you can watch the video as I talk, where basically all you need to do is capture a reference image at the start of the 4D simulation. You place that gray patch on their belly, and you can observe their breathing, whether it's consistent or not. It gives you feedback, and then you can move the patch if necessary. It will calculate your BPMs, and as soon as you are happy and ready to press the button, you'll see kind of a yellow background appear, and it automatically will identify that the scan is done because it's triggered by the sim. And then you scan, and that's basically it. Once the scan is done, and I'll fast forward a little bit, and you can see the surface as it moves into the bore. Once it's done, it automatically notices when the radiation stopped, and you can review your scan and push it to be reconstructed. So it's as easy as that. If you ever need to do a DABH SBRT, the workflow is similar, where you capture your surface, you place your patch, you coach the patient into breath hold, and you use the system to make sure that they are holding their breath within your appropriate thresholds. And then you scan it. You coach them again for breath hold, and you start scanning, ensuring that their breath is staying within the thresholds. So that's simulation. Let's talk about planning. So surface-guided planning with MapRT, where MapRT is a newer product from VisionRT that provides a clearance map at the beginning of the scan by capturing the 3D surface of the patient from head to toe. It can capture anything that you place on the table, any accessories or immobilization devices. That clearance map can be used to optimize the plan, as I mentioned. You can know exactly which fields will clear or not right off the bat, and you can open the door for non-coplanar treatments or other kind of complex plan that you might think of. It eliminates the need for a dry run or collision check prior to the patient starts, so it's a big time saver. Here is our setup and how it looks in our sim room. We have the two lateral MapRT cameras, and then the one SIMRT camera looking down the bore, and you have the two workstations that are mirrored from outside and inside the room. And this is the clearance map that you would get once you scan. So you can divide it into almost 5 parts. If you already have a plan in place, which in this case we do, you can see the plan information here. If you didn't push a plan yet and you're looking at just the preliminary view, which I'll explain what it is later, this will be empty. The red are the collision areas, the yellow are the fields. If it's a big line, it's an arc. If it's just a dot, it's a static field. Here you have the virtual Linac room where you can test out different couch angles and gantry angles. You can also move this crosshair around. The x-axis is couch, the y-axis is gantry, and this will move automatically. This side is the patient, is the safety buffers of patient and couch. And here you can manually move the isocenter to test different isocenter places, and you can manually move the couch if you want to change indices. So let's continue. So our workflow is pretty simple. Before we sim the patient, we set them up on the sim table with all their mobilization devices and accessories, and we capture their surface. and we take a look at the preview mode. So it's basically just gives us the clearance map, those go and no-go zones, and we kind of take a look if everything makes sense. For example, if it's a prone patient, the prone position clear? If the accessories might stick out a little bit, or the elbows are up or something like that, we kind of test different gantry options to make sure that it makes sense. If there's any questions, the therapists are comfortable calling us, either me or the physician or both, and then we kind of make a group decision on it. But once everything looks good, we scan the patient. The planner gets the clearance map and the DICOM information, and they start planning. Now we have a working API if you're planning with Eclipse, which we are, so they can run the script constantly as they are iterating the plan to make sure that their choice of fields and couch angles are clearing. Once they're happy with it, the final clearance map goes back into the patient's plan. So the therapist, when they get the plan for their plan check and physics, they know that it's going to clear. So here's an example of an SRS case with 3 lesions that were previously treated, and we are retreating different areas. And so standard non-coplanar SRS plan. So you can see the arcs are going this way with different couch orientation, and we look at this, we know that it's going to clear, so everything looks good and no concerns. With our SBRT lung, is something that we have had less experience with. With the cranial, we have hyperarc now, so it's very, very streamlined and easy to use, and it has a built-in safety for the non-coplanar arcs. But with SBRTs, it was a bit of a uncharted territory for us. So we have this patient with a lesion that was really close to the heart, and our dosimetrists really wanted to try a non-coplanar approach. But they're not as well vested in it, and so we started using these cases as a teaching case to see how we can really improve dosimetry with introducing non-coplanar for different areas except the cranium, and this is what we came up with. So our standard VMAT plan would have been about 5,400 MUs, and you can see it labeled as SBRT lung coplanar, and it had some coverage issues and max dose issues to the heart. But by introducing a 20-degree couch kick, we were able to reduce the MUs by almost 1,400, which we're at the point where we're comfortable moving the couch from outside the room because we have about a year's worth experience with MapRT and collision mapping. But for institutions that don't and they prefer to move the couch from inside the room, that MU buffer will wash out the time savings that you would get. So the 2 or 3 times that you might have to go inside the room and move the couch, you save by delivering less MUs. But looking at our SBRT constraints, we see that we have improved on every aspect almost. So the non-coplanar is a better plan, and we went with it. But before we kind of get excited, we really have to check the clearance. And this is one of our earliest cases, and we see a lot of red, which means there is a collision on arc 2, and you can see it here. So going back to it and looking what's colliding, we see this something that looks like a sheet that's hanging. So this is one of our learning curves where we've learned that we need to tuck in our sheets, but we tested this out quickly on day 1 to make sure there's nothing really hanging, and this plan was delivered as is and it cleared. So that was crisis averted. For those with RayStation planning system, MapRT fully integrates into RayStation, so you get your clearance map as a window and as part of the field. So that's good. So this is an example of a non-clearing field, and that's what you will see when it clears. For users, now we have an API where you can call it at any time, and you will get a message of fields that are clearing or fields that are not clearing, and then you can call on the clearance map and kind of check it if you have any issues. Looking at treatment, surface guided treatment with Align RT brings a lot of, about 15 years worth of technology into the treatment vault, with biometric facial recognition to postural video to improve patient setup and accuracy, markerless treatment, so you can quickly go tattooless. You have a deformation view to assess patients' changes in body habitus, motion management, and sub-millimeter accuracy from head to toe. So as an example of prostate SBRT delivery, we're setting up to a surface, not just 3 tattoos, and we're monitoring that patient throughout the whole treatment, and we can use automatic beam hold if the patient moves out of tolerance. So that's an example of the postural video. That's an example of our ROI and our monitoring. So, with all these little intricate lines, we can perfectly set up the patient. And I think the last year, maybe 1% of patients got a second CBCT due to alignment issue and not, a bladder not being full or something like that. Similarly for SRS, we can use postural video to monitor the patient and make sure that the ROI is covering the open face mask to really, really make sure that they're staying still. There's also a respiratory model that is fairly new and combines the ability to do amplitude and phase gating that are devices on the LINAC. And my time is almost up, and I quickly want to jump on the last section of the talk, which is dose, utilizing real-time verification of dose with Cherenkov imaging, so we can see the treatment delivery in real time. And this harnesses the Cherenkov effect. For the physicists out there, the big blue glow that we see in nuclear reactor images won a Nobel Prize almost 100 years ago, which, if you think about it, it's the analogous of a sonic boom, but with light. But we can use this Cherenkov camera alongside with our SGRT cameras to view the radiation as it's being delivered. And this is what you really see on real time. This product came out of Dartmouth, and you can scan these QR codes if you want to see the initial studies. And they've shown that about 10% of cases cannot be visualized only with dose RT or Cherenkov imaging, and it's stuff like chin, like MLC leaf error, or bolus misplacement, or a chin in the field. And now we can detect all that with dose RT. So looking at SBRT example, and this is a long SBRT. I'm playing the video as we go. So this blue light, the gantry is moving. This blue light that you see is exactly where the radiation is being delivered as the gantry moving around. This is a snapshot of one, and then we can call on the cumulative map of the whole plan, and you can see that the yellow is when a lot of the radiation was dumped, and these strands are kind of the staying along arcs. You can see the entrance and exit dose. So it's pretty useful in a lot of cases, sometimes in SBRT2, where we can see that, we are, if you kind of 3D project it into the patient, that we are treating the right area. SRS example, again, for multiple lesions, we can focus on a single lesion and at a time and kind of see where the dose comes and goes. Again, an example of screenshots from the delivery, and you can kind of starting to see it trickle through as the gantry is rotating. And this is kind of a cumulative dose, view dose of one of the lesions that was treated. So to quickly conclude, what I was talking about today was 4 products coming out from Vision RT. SimRT provides a quick and easy way to capture respiratory motion information during CT. It's effective, non-invasive, and simple to use. MapRT will provide a clearance map that eliminates the need for collision checks and dry runs, while assisting in improving the quality of the treatment plan. AlignRT provides a markerless patient positioning and monitoring, will greatly reduce the need for repositioning and reimaging the patient. And DOSE-RT provides dose visualization in real time and assists in improving the quality and safety of treatment delivery. And since I always get asked about this, I'll put it at the end of like a few future development that we're working on. So MapRT is looking for a full API integration with Eclipse and surface matching between the DICOM surface and the MapRT surface, so you can kind of test correct and incorrect positioning, so you can further improve your clearance map. With DOSE-RT, we are working on dose linearity, so instead of getting a qualitative assessment, you get a quantitative assessment with dose instead of signal, and other kind of measurement tools. And with that, I want to thank these people for helping me out with the process. And that's it. Thank you all.
Thank you. That was great. We have some questions, so we'll go through questions. And by the way, Dr. Koontz, behind of you, there's palm tree, and it's good to see palm tree too. I appreciate. So a lot more physics questions than physician questions, but we have some questions for Dr. Koontz. I'm going to go back and forth between Dr. Koontz and Dr. Robinson. So okay. Dr. Koontz, SGRT insurance coverage for SBRT, if you use RGRT imaging and SGRT, does the charge different?
It's a great question, and I'm lucky in that we have a whole team that I let work through all of the insurance nuances. But in general, yeah, you are right. Just like how IMRT is bundled, SGRT is also bundled, and so we not always do we use IMRT with stereotactic radiation, but we can. And I think the same thing, and I'll let Adi mentioned, but I think the surface guided component is going to get wrapped into the stereotactic piece. Adi, your experience?
Yes, it is definitely bundled. But as you mentioned, especially for MapRT and DOSE-RT being a newer product, it opens the door for different kind of billings and again, different, it might vary from center to center, but for example, in the near future, when DOSE-RT becomes a more quantitative assessment tool, then it opens the door to bill for in vivo dosimetry daily, basically on each fraction. You can utilize some special consults codes if it's not bundled through the IMRT stuff, if you're doing a complex plan that involves all these tools and all these times from the physician and the physicist. So there are ways beyond just the imaging code to get some reimbursement on these technologies.
Yeah, this is important not for charge necessarily, but to monitor. Dr. Robinson, can this SGRT system be used with all these imaging detectors in place? Would it interrupt the view?
Yes, that's a good question. So first of all, with MapRT, in the virtual LINAC room, you can actually pull out the imaging arms to make sure that the patient clears with the imaging arms out, all three of them, and with electron cones. But if you have, let's say if you're taking a CBCT, so you have two arms coming out, rotating around the patient, you will get some drops in your frames per second. So the quality of your monitoring might drop or be a little laggy. But I think 99% of cases you will not treat with those arms out. So maybe only your MV panel will be out if you want to take MV images in an SRS case at different couch angles. So during treatment, there's minimal obstruction, and you have three cameras, one looking down the head of the couch and then two lateral ones. So as long as you have at least two cameras that are seeing the patient, because one will always get blocked by the gantry as it's rotating, you should be good.
Yeah, and then Dr. Robinson again, and do we need a large CT bore for this MapRT?
No, ours is not a big bore. Patients with bigger, bodies might have some blocking, so you might have to be a little creative with your patch. but as long as they fit through whatever fits through the bore is whatever MRT will see. So it's customized to your sim.
And this MapRT, you showed a gantry and in 3D view.
Yeah.
Can you simulate electron cone as well?
We do sometimes.
So it's not just for photon, but if you put electron beam, then it shows the cones with the gantry.
Yes. Yes.
Oh, awesome. Yes. Okay. Yeah, I'm interested in electron because a lot of collision happens with electron more than photons, and sometimes we cannot really visualize, we cannot imagine that well until we actually set patients there.
Yeah, well, and that goes beyond the stereotactic piece, but we had a case today where we were setting up that, an electron boosted, and the surface guided is a really nice secondary check, in addition to all of the other steps that we do when setting up a treatment planning system derived boost.
Yeah, so Dr. Yoo, the advantage with MapRT is that you can place your patient at their setup in the virtual linac room before you even did the initial CT scan. So before any radiation was delivered, you can test the setup and see, well, the electron cone's not going to fit, or the KV arm's not going to fit, or this immobilization device needs to be cut or moved or adjusted or prone versus like you can make a ton of adjustments without even delivering one photon.
Without even CT image?
Without even a CT image, all based on the surface from the two cameras. And then, once you agree on it, you can scan, and then if there's more tweaking, you can do it. But it's really not based on DICOM CT, it's all based on surface captures.
Okay. And Dr. Koontz, for liver SBRT, do you use fiducials?
So ideally, yes. There are some we don't do for all patients. I think that it is often based on location and whether our interventional radiologist feels comfortable placing those fiducials. So we've actually done it both ways. I think the advantage to the fiducial is we can sort of use a more traditional fiducial matching, but it's sometimes hard to see liver on our cone beam CTs. But we've done both, and there are certain settings that you can play with with your CT settings to try to help with being able to see that tumor, versus a lot of times you're also looking at diaphragm and ribs and vascular structures in the liver. So where you're using not just tumor, but all of those to make sure that positioning is right.
Yeah, we have a few more questions. We only have 7 minutes left. Dr. Koontz, in clinical practice, re-radiation. So what's your guideline? It's not related to SGRT, but it's related to SBRT. So when you consider stereotactic, SRS, SBRT, re-radiation, do you have any guideline, or what kind of your standard is it? How do you approach accumulate? How do you evaluate accumulate dose and dose constraints? Where do you get this guideline? And also target delineation. Any of your thoughts?
So it depends on the structure you are retreating. High tech does have some guidelines around reirradiation. The one I'm thinking of in the moment is in the spine setting. Definitely stereotactic radiotherapy is, I would say, the standard of care when you're doing reirradiation. ACRO is coming up with, so we have the metastatic pathway for guidelines around how to treat metastatic disease. And in our next version of the oligometastasis pathway, we are going to include guidelines around reirradiation as well. So briefly, yes, there are both ACROs coming out, and and published guidelines already to support.
Okay, and Dr. Robinson, for the long SBRT example you showed, it was about 5,000 MU-ish. What was the prescription for that?
I don't remember, but it's probably like around 1,100 a fraction or something like that.
Okay, because the question, the one who asked the question asked if it was 11 gray, it was right, 11 gray, and how complex the plan was. for that one?
It was modulated enough that it was 2 arcs, so it can't be like too complex. But the main problem was the proximity to the heart, and we wanted to spare the heart as much as we could. And there was no, we could have approached it with a lot of semi arcs and complex coplanar treatment, but the non-coplanar 2 arc approach was a lot simpler, quicker, and easier on both the patient and the planner. So we went with that approach, and that's kind of what we're trying to build up program here, where parallel try both approach and find the best plan that we can deliver.
Yep. And Align RT, does it use rigid registration only, or does it also have deformative information we can apply?
So yes, it has a deformable view that will show you kind of changes in the surface compared to what DICOM is, and we use that a lot to assess patient weight gain, weight loss, and so on and so forth in a lot of cases. Yeah, so it has both.
Yeah, and for cases with Dr. Robinson again, cases with the bolus for the in vivo dose, the Cherenkov imaging, was there any difficulty to monitor if there's a bolus like chest wall patient?
No, so I have a famous slide that I can show, but since it's not in the scope of SBRT, I neglected it. But we've had a case here where it was a chest wall patient where the bolus was misplaced on fraction 8. And the therapist saw it after about 3 MUs. You can clearly see signal is not where it's supposed to be. And they were able to pause treatment, adjust the bolus, and continue treatment in a case where it might have never been detected. And we would have delivered the full fraction with an area that is underdosed and an area that's overdosed because of the bolus not sitting well. So the bolus doesn't interfere with the signal because the signal is able to transmit through the bolus, and we're able to see exactly the field size on the bolus and decide if it's placed correctly.
So does it show what to expect, or did therapist remember what to expect?
It just shows you in real time what is happening. It doesn't show you what to expect.
So there's no reference, but somehow therapists remember what it should have been, so they transfer it.
Right now, I'll say right now, no, but maybe in the future that would be an added product. But the therapist, the more and more they see these things, they kind of know what to expect, and they kind of know when things look weird.
Yeah. Okay, I have 2 more questions. I want to go through even if we go over time. Dr. Koontz, have you decided to re-CT, like re-simulate and replan because this SGRT was not working well for certain patients? Not because of cone beam CT, but SGRT, surface guidance.
So I haven't come across cases like that.
No.
All right, okay. But if you replan re-CT, it would be mainly based on like cone beam CT internal organ change. Is it correct?
So the surface is based on external, like the external surface of the body, and the way we work is, by taking IGRT and capturing the surface at IGRT, we're basically correlating internal to external anatomy. So if there's any changes in the patient's body surface that requires a re-CT, then we will just update the surface that Align RT is being used. But any shifts or minute changes that is visible in CBCT, we can just recapture a new Align RT surface, and that compensate for that change. So we're monitoring the daily, most updated surface at all time.
Yeah, and I'll add to that, Sua. So, I mean, I think, so we are still using traditional image guidance.
Yes.
The surface guided acts as a secondary, number one is a secondary marker. So it's a secondary check that we're precise. And then the other, it can help us, for example, with breath hold. So the degree of breath hold, that's a great example of where we'll see changes on the surface that are not necessarily as obvious on the cone beam CT based imaging. But the other part, as Adi said, is that it allows us to, we can adapt that surface based on the on where we're lighting. So it's a second check. It's not the sole component of patient setup.
Yeah. And one last question with this SGRT, like Align RT monitoring patient, have you had patients that you just have to turn off or ignore because it was keep kind of interrupting treatment? You know that the patient setup internally everything is good, but it was keep going off the threshold.
No, because you have different layers of monitoring that you can do. You can let it monitor in the background and not beam hold. So it might fluctuate.
You might change the setting in that case, right?
Yeah. So
still monitor.
Yeah. So you can just monitor it manually. You can have it automated, or you can technically shut it off after. So you can use it for setup only, setup and monitoring without beam hold, and setup monitoring with beam hold. So you have kind of 3 levels of doing it.
Yes. All right. I think we went through most questions. Thank you so much. And
thank you for having us.
Yes, thank you. Should we close it here? Carrie?
Yes, thank you so much to Drs. Koontz, Robinson, and you for taking your time to support our educational mission.
Thank you.
Attendees, look in your inbox for a follow-up email with details on how to obtain your CME certificate. We hope you appreciate these webinars and will consider supporting the RSS by becoming a member. We do have 2 more webinars coming up in the next few weeks. On April 24th, we will host the emerging role of stereotactic ablative radiotherapy for pediatric and AYA malignancies. And on May 8th, we will be hosting off-ISO Winston-Lutz Solutions QA Series 8. Registration for both webinars is available on our website. Thank you again to Vision RT for sponsoring this website. And this will conclude today's webinar.
Thank you.
Thank you so much.